and admitting everybody. Hi, everybody. My name's Kathleen. Welcome to the WPC Partner Highlight with the Women's Parkinson Project. We'll get started in just a minute, but there are a few housekeeping items I wanted to go over with you. So firstly, as you've been alerted by Zoom, this session is being recorded and will be available after this call in English and in Spanish. And that will be on our YouTube channel. All audience members are going to be muted for the duration of this call. If you have a question, please put it into the chat. The chat icon is on the top or bottom of your screen, depending on what device you're using. Simultaneous Spanish interpretation is available. If you click on the icon that looks like a globe on the bottom of your screen, you can choose the language you would like to hear the discussion in. And if you are on an iPad or an iPhone, you might not immediately see that little globe. It'll be on the 3 dots on the side of your screen, and then you can choose language interpretation and select the language. And now, just in case you didn't understand a word of that because you were hoping to hear it in Spanish, I'm going to hand it off to one of our fabulous translators, Sibella, to give you the rundown again.
Kathleen, you need to unmute Sibella.
You have so much power, Kathleen. Buenas tardes a todos, bienvenidos, bienvenidas en este día a este evento. Simplemente voy a repetir lo que ha dicho Kathleen por si hay algún despistado no se ha dado cuenta de que hoy tenemos servicio de interpretación simultánea. En la parte inferior de su pantalla o el superior, si están utilizando otro tipo de dispositivo, hay un globo terráqueo donde pueden activar la interpretación y seleccionar el idioma que deseen escuchar. En este caso sería el español, para poder oír lo mismo que están oyendo ahora. Y como ha dicho Kathleen, esta sesión está siendo grabada y estará disponible en el canal de YouTube del WPC en los próximos días, las dos versiones, en español y en inglés. Los micrófonos, como han podido comprobar, están apagados y no podemos encenderlos. Pueden hacer sus preguntas si quieren en el chat y pueden hacerlas en español, no se preocupen, nos ocuparemos de traducirlas en su debido momento. Y nada más, muchísimas gracias por participar en este evento del WPC y de Women's Parkinson's Project. Adelante, Eli. Eli, it's your turn.
Thank you, Sibella. Thank you, everyone, for joining us today. I want to welcome you. My name is Eli Pollard. I'm the Executive Director at the World Parkinson Coalition, and I'm incredibly excited to have you all join us today on International Women's Day. The World Parkinson Coalition has come together with the Women's Parkinson's Project to host this webinar to celebrate so many women around the world who are living with Parkinson's, researching Parkinson's, treating people with Parkinson's. It's an incredible community, and just looking at some of our panelists today, it just showcases and highlights some of the amazing women in our community. I also want to thank our sponsor, Kiowa Kirin, for making this webinar possible and for ensuring that we could offer this with Spanish interpretation. This is the first time we've ever done live interpretation on a WPC webinar. So thank you for your patience and our few minutes of starting a few minutes late. It is very exciting to have this, and we look forward to continuing this sort of work in the future. So also, if this topic excites you, I hope you will save the date to attend the 6th World Parkinson Congress to be held in Barcelona, Spain from July 4th to 7th next year in 2023. And a special treat for those of you who stick around with us today to the very end, I will be choosing one name to offer a free registration to attend the Congress next year, compliments of our sponsor, Kyowa Kirin. So you can learn more about the Congress, and if you stick around to the very end, your chances increase of winning a free registration. I will now hand off to our moderator, Rochelle Flanagan, who also happens to be a WPC Parkinson ambassador. We're thrilled to have Rochelle lead the panel discussion today.
Hello, I'm in. So hello everyone. I'm just going to, can I share my screen there, Kathleen, please? Yeah, great. Okay, share. Okay, so just as Eli mentioned, I'm a WPC ambassador, and how I became an ambassador was that I 2 years after I was diagnosed myself with young onset Parkinson's disease, I attended the WPC in Kyoto, and it was basically life-changing for me because I met a lot of people with young onset Parkinson's disease, and it took a lot of the fear out of it for me. And it was actually then at the WPC that I met two of my best mates now, Katil and Sri Sripathy, through the WPC, and we realized through our sort of own experience that women had different needs than men in terms of our symptoms, and particularly around our menstrual cycle, that we noticed our symptoms were worsening and things like that. And we decided to co-found the Women's Parkinson's Project to raise the voices of women with Parkinson's for better treatment and research. And also subsequent to that, we ran a survey both in English and Spanish looking at the impact of hormones on Parkinson's symptoms. And these surveys are still available, and we'll put them in the chat later on if people would like to take part in them. And really the reason why we're having this webinar is as a result of a paper that we recently published that arose out of the surveys we did and some other webinars that we did over the past year. And this paper really highlights the unmet needs of women with Parkinson's disease. And again, we can put the link in later on. In terms of the webinar tonight, we had over 600 people register, which I think really shows that there is a need for women in terms of their voices being heard. And this word cloud basically highlights the kind of key comments that people put in the registration form. So you'll see things like progression is a concern, hormones, dementia, DBS, fluctuations, medications. There was a lot of things that women were concerned about that we're going to try and address tonight in the webinar. I'll start to address. So I'm going to bring you on then to the panel. Tonight is made up of the authors of the paper. So we've got Professor Indu Subramanian, who's from Los Angeles, her colleague, Dr. Adrienne Keener. We have Professor Elena Morrow from France. We have Sonia Mather, who's was a practicing doctor and lives with YOPD and a PD advocate. We have Anne-Liane Oosterban, who is a gynecologist and also an advocate for Parkinson's. And we have Dr. Maria Teresa Ferretti from the Women's Brain Project, who is a neuroscientist and a neuroimmunologist. So delighted to have them all along tonight. And just, to mention why we're doing it on today, and it's because today is the International Women's Day, and the theme is breaking the bias. And we want to basically launch this as a platform to help break the bias in terms of having women with Parkinson's needs met. And this is a picture of a number of colleagues from Parkinsons who are very gratefully have organized the translation for tonight. So thanks very much for listening to that. And in terms of the format tonight, we have about 45 minutes of question time. So what I've done is taken the questions that people have submitted, and we had of say 600 submissions of questions. So we picked some of the salient ones, and we're going to put it to the panel. But you can put questions in the chat, and my WPP colleagues Shri and Kat will try and answer questions during the webinar. And if we have time, we'll ask some more to the panels as well. So I'm just going to stop sharing here. So I'm going to start off. There were sort of different themes around sort of clinical questions, hormone related questions, social sort of related questions. So I'm going to start off with the clinical ones, and I'm going to direct this one to Indu to start with. So one of the questions that came up, Indu, is, are some medications more effective for women than for men? And have you found that women might need lesser amounts when using the same medications as men? So Kathleen, just need to unmute Indu.
So that's a great question. I don't think we have the answer to do certain medicines work better in women, but we definitely have a sense that women metabolize things differently because of our body weight being smaller. I think a lot of medications have been trialed in largely white men who are older, and so the body weight is quite different than, let's say, someone like you, Rochelle, or Anne-Lienne. So often because of this disconnect, especially for levodopa dosing, sometimes we tend to overdose, sometimes women. So we really have to kind of listen to your symptoms and understand kind of how much you need, and sort of make kind of a customized approach to your symptoms and your daily life activities, and hopefully that will be done in the future, given this paper and highlighting this important topic.
Thanks, Indu. And Maria, if I could bring you in, Maria Teresa, I know that you research other neurological conditions that have a high prevalence in women, such as Alzheimer's. Have you seen, a difference in terms of medication, having a different, action in other conditions? So, Kathleen, if you wouldn't mind unmuting Maria when you have a chance, thanks. There you go.
Am I on? Yes.
Yeah.
So hi, what I would like to say about this question is that actually there are a lot of differences, and they apply to different neurological disorders, but it's a general topic in medicine. We are even seeing it with vaccines, and this is a very hot topic right now. So drugs do not work the same way in men and women, and we have a lot of examples. One reason is for sure what Dr. Subramanian has mentioned, differences in the way our body metabolizes the drugs, but it's not just that. And I want to say that women are not just small men. So whatever differences we're talking about here today about Parkinson, there are differences in the workings of antidepressive drugs, differences in multiple sclerosis. All these differences have multiple reasons, and some are really biological in the way our bodies interact with drugs and respond to them. And I do think that we need to do a lot more research to understand why.
Thanks a million, Maria. And I suppose that, would you say, Indu, that if women are noticing differences, that they should bring it up with their neurologist and sort of say, look, I notice my dyskinesias are getting much worse. Do you think it's something that they shouldn't be afraid to mention to their neurologists?
Yeah, I mean, I think that hopefully with this paper, and I know, it was a lot of work on the part of many of us to put this paper out there, but now that we see it in writing and we show the sort of, life cycle of women and the hormones and how they change things, hopefully this will be a point of starting a discussion with, our healthcare providers, and women can actually take this paper in, and I've printed it out for some of our patients as well, and shown them kind of, with the graphics, what these differences can be and how the hormones may interact. We also have some other webinars floating around. Anne-Lienne and I had recorded a webinar around, the actual various changes in menstrual cycles, and, the various hormones peaking and troughing, and also with the perimenopausal time period. So I think getting educated and then coming forward, there are some very simple motor diaries out there, and I know that this team here also wants to try to find better ways to track symptoms around the period. And many of you have told me that, for a month, a year, a week, a month, so 1 in 4 weeks, you're not feeling so well. So I think that it merits sort of bringing that to the attention, maybe filling out some of those motor diaries in different days of the month, and then bringing that in, and perhaps, catering medications to, or lifestyle choices even around some of these symptoms as they exacerbate. You might need more sleep, maybe more yoga, maybe a hot, soak in the tub. It may not just be adding a medication, so I think there's many approaches, but first is actually recognizing that this is a problem, which I think we've started to at least have a chat around here now.
Yeah, and maybe to highlight, when we did the survey originally, we did it of 209 women, and 147 of them were still menstruating, and 84% of those women said that their symptoms were worse the week prior to their period, and 49% said that their symptoms are worse in the third week of their cycle. And I believe that is to do with potentially the drop in estrogen, which affects the dopamine levels. So obviously, in terms of women with Parkinson's, then that drop of estrogen has a bigger impact on us because we're already low in dopamine. But in terms of, we've heard that some people are given maybe, extra release dopamine, emergency dopamine like Madapar or something the week before their period, or other people are treated with hormones. Do you find that, it's a bit arbitrary, what people are being given to manage their symptoms? And should we have sort of a more streamlined protocol for it?
Again, I think everyone's very different. So I think understanding your own sort of sense of the cycle, as you mentioned, some people it's the third week, some people it's the fourth week, sometimes it's actually when they've gotten their period. I know for my body, it varies depending on sometimes the month and what else the stressors are at the time. I think the sense that you may be able to modulate some of these with getting on a birth control pill or other sorts of, modulations, I think is something that I know Anne-Leanne is very passionate about understanding more. I think it is rather arbitrary just because we're gathering data, and for women, I think, each of us is very different depending on what stage and, what other, sort of medical issues are happening, or the cultural context. And I think, so much of my chats around managing Parkinson's in 2022 is really meeting people where they are who are living with this disease and understanding, what brings them joy, what are their daily activities, what are the things that they want to try to do, and then understand who they are as a person and what we need to do to cater, in a personalized way to those sorts of issues that they're having. And maybe that's lifestyle choices, maybe that's adding an extra dose of levodopa here and there. And it is kind of arbitrary, but that I think just speaks to the sort of, the multi-dimensional sort of, lattice work of all the beautiful people that are on this planet. So I'm an Indian woman, you're an Irish woman, we're all very different genetically. I think there's so much that makes this disease complex at baseline, even in thinking about the white, sort of male that we've sort of branded this disease around, and now bringing in all this sort of richness of, our cultural context and who we are and what we do every day. I think we really have to cater, this and the treatments and the approach to, that personalized kind of bespoke kind of care for each of us.
Yeah, thanks a million, Andrew. So Elena, I'm going to move on to another topic which is quite diverse in terms of the questions, but one of the big things that came up actually was dementia. So one of the questions was, what is the likelihood of getting dementia from Parkinson's disease? And is the prevalence of dementia higher in men or women? And are there any red flags we need to be aware of to raise with our neurologists? And this was just, I suppose, to put in context as well, in terms of the registrants, over 55% were over the age of 60. And I think that's probably reflecting this question, which I think needs to be addressed.
So thank you very much. And hi, hello, everybody, which is wonderful to have all this huge audience today with us. And indeed, this is a very important question, but we have good news. This is the most important thing, because Maria Teresa talked about Alzheimer's disease, and we know that women are more affected compared to men from dementia, from Alzheimer's disease. But the good news for women with Parkinson's disease is that they are less affected compared to men. It's a very important point, because the question may be why is only because of hormonal problems. We don't know yet. What we know that is there are some risk factors for having dementia in Parkinson in men. For example, the dysautonomia, which probably is more present in men, the hallucination, which usually are more present in men, but also the age, as you mentioned, and the disease duration, they have an impact on dementia. Overall, we can say that the prevalence of dementia is between 20 and 40%, and some studies they show that, of course, with the progression of with the age and the progression of the disease, this prevalence increases. But having said that, and the fact that women with Parkinson are less demented than men, I think it pushes us, as I said, to better understand, for example, the difference why we have more women in Alzheimer, more women with Alzheimer and less women with dementia in Parkinson's disease. And I think this is an important question which can help us in finding maybe prevention and some more effective treatment in slowing down the cognitive decline.
So actually, thank you, Elena, and bringing it to Maria then, in terms of, the research, have you seen much in terms of yourself around Parkinson's and the links? And I suppose for the women here, is there anything that women can do to maybe, change the course of that from a, lifestyle sort of point of view? So I don't know if Kathleen just needs to unmute you again there. There you go.
And I'm back. Yes, thanks. Thanks, Elena, and thanks, Rochelle, for this question, because this is, it's very dear to me and the Women's Brain Project. When we talk about prevention of dementia, we are all terribly scared of dementia. It's a little bit of a taboo topic. It's one of those things we don't even want to think about. And I'm actually very passionate in giving the message based on research that we have accumulated in the past decades, let's say the past 10 years, that actually dementia is preventable. And of course, I'm very into the research of Alzheimer's disease, which is my field, but the evidence that has been collected applies to dementia at large, all cases dementia. And there is actually a very interesting report from the Lancet Commission that has looked at risk factors that can help us reducing our risk of dementia, all causes dementia. And we have 12 risk factors that we can all act on that are modifiable risk factors that apply in general. So I encourage all women and everybody with Parkinson, but today in particular women, to actually take care of these risk factors, and are the usual ones that we all talk about, mostly related to our diet, our exercise, social isolation, alcohol, but even pollution and hearing loss. And the message that I want to give is not really to do this or do that, but I want really to send a very strong message to say that we can prevent dementia. It is not an obligatory way to go there. So if we are in power, we are in charge, and we should take agency over the health of our brain. And there are a lot of things that we can do to keep our brain, and at least, prevent or reducing the risk of dementia. So we can do it.
Okay, thank you. I suppose what's quite interesting as well, just in terms of Elena mentioned as well, that we need to know why is it? It's fascinating that women, it's higher in AD, in Alzheimer's, and it's lower in Parkinson's. And I just saw a paper published in Nature that was looking at FSH and saying that might be something that is the differentiator in terms of why more women get it in Alzheimer's. And I suppose it just points to the fact that, by looking at research into women, we could unlock treatments for men as well, so there are answers within all of our bodies, to hopefully change the course. I might just ask in terms of, someone has asked about Lewy body's dementia there in terms of the difference. Would you be able to speak to that, Elena?
Well, Lewy body dementia is a bit a different disease. In which the accumulation of the famous alpha-synuclein, which is the hallmark or pathological hallmark of Parkinson's disease, is more diffuse compared to Parkinson's disease. And the accumulation is in the spatial areas, which are more related, let's say, cortical areas, which usually in Parkinson's disease, they are affected at the very old stages. So, and this is the major difference from the anatomical point of view. Then, if we consider the etiology, Lewy body dementia is a bit less known compared to Parkinson's disease. And between men and women, there's no a huge difference so far. I think there's a slight prevalence for men, but there are not a lot of studies comparing Alzheimer and Lewy body disease. And often the diagnosis, there's been a lot of misdiagnosis in the past, and now we know that there's hallucination, that dysautonomia is much more frequent compared to Parkinson's disease. Cognitive decline is since the beginning of the motor symptoms. So I think that we still need to know a bit of the differences, but the main hallmark is that the cognitive decline is much earlier compared to Parkinson's disease.
So if people were to sort of have a red flag, that might be the one to look out for is cognitive decline early on with the motor symptoms.
Hallucination, fluctuations during the day, and these autonomic features are very at the beginning of the disease.
Okay, and when you say dysautonomic features, what exactly is
it? Orthostatic hypotension, for example, which is very common and is very disabling. And then urinary dysfunction, for example. But I think the most disabling is the orthostatic hypotension.
And if you were to describe what that is in terms of a symptom for...
Basically is very classical also in Parkinson's disease. When you stand up quickly, you have this sensation that you're passing out, that you're feeling unwell. And the more you stand, you have this sensation of dizziness and that you are falling down.
Okay. So I suppose just to differentiate, for example, I have orthostatic hypotension, but not the cognitive yet anyway. So would it be that it would be, you know, cognitive and the orthostatic would be quite prevalent early on? Would they be sort of flags together?
Yes.
Yeah. Okay. Thank you. So just in terms of, you know, into one of the other questions was, you know, people were quite concerned again about progression. And I know myself, you know, when you're diagnosed and people say it's a progressive disease and you ask neurologists, so how, you know, what pace is it going to progress at? And they say, well, we don't know. You know, and it takes a while to kind of just let go of the fear around that. And I know from research that, you know, pretty much, you know, most go at a fairly slow, benign kind of progression. But, you know, it's obviously something that worries people. And, you know, what do you think that, or what do you say to your patients in terms of what would positively impact their life in terms of, you know, managing that, you know, I suppose fear for one, but also managing to just try and slow progression down?
So I think that it is a very treatable disease. I think that it's, you know, something that I love taking care of. I don't love taking care of many diagnoses in neurology. I think that this is a disease that we have great treatments for. There's a lot of hope. There's a lot of, you know, like was said before, things that patients can do for themselves to really, you know, exert their own agency over how they live every day. And these lifestyle choices can really make a difference in the outcome. And I think, you know, the women that are on this panel now have really pivoted from a very negative sort of possible outlook at diagnosis, you know, and thinking that there isn't hope and that they're alone, to really, I think, you know, embodying what can be done, you know, with a different outlook and with, you know, a team sort of approach with, you know, networking with other women and really finding ways to positively sort of help themselves and each other in a way that I think is really beautiful. And I think that that sort of, you know, sort of sense of empowerment and educational, you know, sort of understanding more about the diagnosis, empowering oneself. And then I think lifestyle choices are huge. So exercise is medicine in this disease. Taking care of yourself in terms of getting good sleep, eating healthy, you know, what you put in your body is really going to reflect how you feel. And you know that as anyone, Rochelle, because you're a dietitian who advises patients, you know, Mediterranean diet, you know, hydrating well. Social connection, I think, has really been underplayed historically, and that's been a passion of mine. But, you know, being lonely, being isolated, being withdrawn, not having cheerleaders in your life, not having people that you can talk to about your problems is hugely problematic for our patients. And so if you're one of those people who has isolated yourself, find your tribe, find a cheerleader and figure out how to, put one foot in front of the other and get some exercise, and, really find people that are going to motivate you to live, well. And so much of what my passion is these days is to understand what that secret sauce is in terms of who is doing well, and try to, break that down and help our patients. But a lot of this is around lifestyle interventions. And I really do think that this is a very modifiable disease in that regard. Medications obviously have their role. I'm a big believer in levodopa treatment and, our amazing deep brain surgeries. But I think that the types of things that one can do, in terms of lifestyle are very powerful. And I do hope to bring that and tease that out more, and find a prescription that we can give all our patients once they're diagnosed. And hopefully that diagnosis will not be delayed, especially in women and young women, as we are doing now. So the future hopefully is early diagnosis and really, getting that lifestyle prescription in so people can feel better and do better.
Yeah, so I suppose, really people should be given a prescription for exercise along with their levodopa, ideally. I think that would make a big difference, because the research at the moment shows that the only thing that potentially slowing progression is exercise. So, but to your point, I know that you did a paper into that showed that actually isolation was even worse than not exercising. So I think there's two strong messages there. So exercise with the group of people,
Yeah.
best combination.
Yeah.
Alina, just in terms of, do you think going on from that in terms of helping to slow progression or halt it, that women taking part in research would help maybe accelerate that potential?
Yes, definitely. And I also want to say that WHO is embracing this concept of brain health as a big concept in which all the diseases can be, most diseases can be prevented by this, what we are discussing, healthy style, exercise, and cognition. I would say exercise also is very important. So this is an important concept, because if the WHO is going towards this direction, it will foster research also for women, right? Because as you said before, to understand a bit the differences, why some diseases are more common in women or in men, and the burden of the disease is different, the phenotype, the clinical manifestation, the response to treatment is different. This will help us in moving on the field and finding a customized treatment. We talk about personalized medicine, and this is where we want to go. This is where all the community, the World Federation of Neurology, the American Academy, European Academy, they want to go. Right, to have a holistic vision, a comprehensive vision of brain health, and also to help, because I want to say that we are always concentrated when people have Parkinson's disease, everything is because of Parkinson's disease, which is not true. We can have also other diseases, right? So we have to put everything into consideration, that we treat Parkinson's disease, but we also want to prevent other problems that, for example, osteoporosis, right? So we want to exercise because we want to prevent osteoporosis, neurovascular disease, which is sometimes together. In the MRI, we found vascular changes in Parkinson's disease, and they get worse. You see how we are all together? So the brain, it works, if it works well, he prevents so many things. And the research understanding these differences in women is very important. And we need to have women in research participating, because if they are aware, women are very generous. They are the first who always want to participate. Research is the way to go to really help the community to move forward.
Yeah, and actually interesting in terms of, we asked the question of, how many of the residents that took part in research, 35% said yes, they did, but 48% said they didn't, and then the rest didn't answer. So I think we've got a bit of work to do, ladies, in terms of getting involved in research. But I think our paper that we published indicated that there are some barriers to that research in terms of women not being referred into centres of excellence where the research would be carried out. You know, and I suppose we need to maybe bring the research to the women, because often women are working, you know, holding jobs and looking after families, and this may be a barrier. So it's something we need to break down, but certainly it'd be great to get those numbers up in terms of research. So thank you. I'm going to move on now to our sort of hormone related questions. So Anne-Lane, who is our gynecologist and Parkinson's advocate. So if Kathleen could unmute Anne-Lane, I'm going to ask her a question. So this came from, again, a registrant. What research needs to be done in relation to the different hormonal stages of women with Parkinson's, would you think, Anne-Lane? Yeah, you've been unmuted there.
Yes. Hi, everyone. I think first we need to further study and clarify the effects of the different hormonal stages, like a menstruation or peri and postmenopause, pregnancy, on Parkinson's symptoms. And once we've got a clearer view on the impact of the hormonal fluctuations on Parkinson's, I think we should set up clinical trials to study the possible positive effects of different interventions like hormonal therapy, or maybe some lifestyle changes, or altering Parkinson's medication, to be able to get to study the possible positive effects of these interventions. And I think we should collaborate internationally to be able to get sufficient numbers.
And how do you think we could do that? Because obviously, you know, we know that there's about 10 million people worldwide with Parkinson's, of which 40% are women. So we have 4 million women, and 20% of those are, you know, under the age of 60. So, you know, in terms of numbers of getting, especially say we're trying to, you know, get pregnant with Parkinson's, we don't, you know, they're going to be spread all over the world. So how do we bring that research together to get those numbers together? How would you suggest?
Well, I think we just should set up big clinical trials and collaborate, like us collaborating already. We should just continue this and set up, because if I just set up a trial in Holland, it would be too small. So I think this is a great start, us getting connected, and we should collaborate in the future to get sufficient numbers.
And I think you have, and we referred to it about having a registry for women, pregnant women. That's something that you're keen to push forward.
Yes, I'm working on it, and I hope the Movement Disorder Society will be keen on hosting this. I'm going to pitch it next month, or this month, I suppose, because it's really important for pregnancy and Parkinson's, specifically to work to collaborate internationally, because the numbers are small, but in the whole world together, the numbers are big enough to get sufficient data. So,
and Elena, could I ask you in terms of how would we encourage the pharmaceutical industry to research hormones in Parkinson's, and back to the point of Anne-Lane, that maybe numbers are, you know, worldwide rather than, you know, big set, you know, that you can run a trial in say pregnant women in Holland, there wouldn't be enough numbers. How can we encourage, you know, because obviously it's a big part of it is the funding through drug development, and is there a way to engage?
Well, it's a complicated question, right? Because part of the reason why women sometimes are less involved in clinical trials is that they have to take contraceptive pills, right? Because most of the drugs, we don't know the effects on the embryons, so they have to take anticonceptional treatment, otherwise you cannot participate to clinical trial involving medication. So this is already a big issue, right, when you want to do a clinical trial. But I think one powerful and important reason can be to convince that if they understand, as we said before, the differences in some motor and non-motor symptoms, women, they have a less severe progression of the disease, which can be the key to find a neuroprotective drug. So if we convince them that we need to understand why this is happening, it can be interesting for them to investigate a little more on differences. Keep also in mind that the preclinical studies are mostly done in male rats, in male mice. So because they're bigger, so it's a bit easier, and then is easier to manage them compared to female animals. You understand? So we have to work also this preclinical level to increase the knowledge about this difference. So I think this is important. And then also we didn't touch this point, but also the gut, right? There is a lot of interest around in the microbiota. And we don't know yet the difference between men and women. Again, there's this microbiota interacts with the medication. There is an increased metabolism or reduced metabolism. So again, to help the pharmacological industry to understand a bit better the difference, can make the management of Parkinson's disease a little better and move also a little faster for neuroprotection. Because, and then I give the words, when we talk about the difference in the severity of the disease, there are some research saying that the inflammation in women at the brain level is less strong. And maybe also the reason why COVID in women was less when say severe compared to men. So if there is less inflammation, a sort of a little more protection, maybe for the hormones that we describe, we can help the drugs to be better developed.
Okay, I'm just going to bring in Maria actually, just in terms of, Maria, I know in terms of say with COVID and the vaccine, originally it was like, no, pregnant women shouldn't have the vaccine. And then they suddenly realized, oh my gosh, they should have it. So are we kind of, I had one woman who said to me that, and actually several women who have been put off having a pregnancy because they were told that they couldn't have certain medications, Parkinson's medications, and so they couldn't tolerate the Parkinson's symptoms for a whole 9 months. And it just seems really cruel. So have you any view on that in terms of how, should we be, just because it's difficult, does it mean that we shouldn't be trying to find answers?
Absolutely, Rochelle. And if you remember, actually, this was even a topic we dedicated an entire panel at the Women's Brain Project Forum in 2019, I believe, because it's a huge topic. It applies to Parkinson, but also to other conditions. That during pregnancy, basically there is no evidence-based medicine to treat, to guide treatment of a number of conditions in pregnant women because they were not included in the clinical trials. And of course, it's a very complicated issue because you don't want to risk anything during clinical trials involving pregnant women. But then when you don't do it, you end up in the situation that we also during the development of the vaccines for COVID, that you end up with a drug that seems to be working and you don't know whether you can give it or not to women just because they were never involved since the very beginning in the study. And so we just published a paper actually where we discuss a number of examples like this. I think the development of COVID vaccines has exposed how little we are thinking about these sex differences during drug development. And this is one of the aspects, but then there is the safety, the efficacy, the dosing, and a lot of other things. And we are really calling for a reconsideration of the way we think about, like Elena was saying, from the preclinical drug development to the different stages of clinical drug development, we really have to reconsider how we are doing this to make sure that we capture the sex differences and we can actually meet the specific needs of women. Because right now, the standard way of doing things really doesn't consider that. And we think about it only afterwards when a problem comes. And we should start being proactively thinking of innovative ways to develop drugs or optimize current drugs so that we can actually take women's needs into consideration. And if I may, just a comment on your previous question on how do we convince pharmaceutical companies that this is something that we need to do. I ask myself every day this question, and I just want to highlight that we have just started a project that I think might give an answer to this, because we have to make the point that there is, I don't know exactly what word to use to be politically correct, but there is, that is convenient, that is important, that there is a gain in addressing these sex and gender differences. And so we are starting a health economic study to actually show that when you don't consider the differences between men and women in a neurological condition, you're losing opportunities, and you're losing in terms of opportunities to cure, to treat, the socioeconomic that goes around, the caregiving piece and all that. So I think if we can convince and if we can measure, quantify this, and we will have really some tools to convince policymakers, regulators, and also developers, drug developers, there is an interesting case. You know, this is an interesting case for them. It's not a problem, it's actually an opportunity. And that's what we are trying to do with the Women's Brain Project.
Yeah, it's amazing that we have to justify 50% of the planet. It's worthwhile.
Exactly, exactly.
So, and Liane and Sonia, I'm sorry, I'm coming to you now because it's sort of we're moving on to the questions pertinent. So, Sonia, in terms of talking about pregnancy, can you be pregnant with Parkinson's? I think you're probably a good example that you can.
Yes, I think I am an example of that. Can you hear me?
Yeah.
Okay. I actually had all three of my daughters following my diagnosis. I was pregnant with my first. So yes, you can be pregnant and have Parkinson's disease at the same time. I mean, if you think about it, Parkinson's disease probably occurs in people under the age of 40 about 5% of the time. But Parkinson's disease is also the fastest growing neurological condition. So the absolute numbers of women that are going to be in this sort of childbearing age are going to increase. I would like to say that during my research for this paper, I saw that there has been an expansive amount of research being done, but as you heard earlier, there really hasn't. We don't have any clear guidelines in terms of how a woman should manage her pregnancy, either pregnancy planning or during the pregnancy, or what the risk is to the fetus, what precautions should be taken, et cetera, et cetera. So it's, that is one real unmet need. And as Elaine said, she's working on a registry because I think we have to, collect the information before we can make management decisions. But it's something that really needs to be looked into.
And can I ask you, Sonia, in terms of, did you have any issues with regard to your medication during pregnancy that you had to stop, or, how did you manage that?
Yeah, through my research at that time, now my oldest is now 23, so this is quite a while ago. What I was able to glean was that my levodopa was probably okay to take, but since I was early enough along in my disease, I chose not to. And again, that probably put me through a lot of suffering in a way, because I was not on medications during pregnancy, because I really wasn't sure. No one could tell me the answer to that question. So that was one situation that definitely changed. And people just really didn't know what to do with me. Was I a high risk pregnancy? Was I a low risk pregnancy? What precautions do I need to take as someone with Parkinson's disease?
So I might just bring on Liane in then, because, fast forward, whatever, 20 years, 23 years, and Liane has 4 kids, of whom the youngest is just, I don't know, a few weeks old. What 4 weeks old now?
4 weeks.
4 weeks. So congratulations, first and foremost. But how have you experienced? Have things changed in terms of, advice from, Sonia's day to now?
Well, I think not much has changed. Still, we think levodopa monotherapy is the safest therapy to take in pregnancy. And that's also what I did. I switched from my dopamine agonist to levodopa before pregnancy. Since there's just most experience with this med, and no birth defects have been described, but still, there's just not that much data, so it was still a little bit how do you say it, scary maybe a little bit for me, but eventually it all went fine. And I would never advise someone to stop medication, since this will only make your Parkinson's symptoms worse, as you heard from Sonia as well. And maybe we know a little bit more about genetics at this moment, but still not that much. But I would give a woman who considers pregnancy the advice to visit a genetic counselor before pregnancy. I did that as well. And furthermore, I think we don't know that much, but I would never advise a woman not to become pregnant, because it is possible. And I felt fine during the way, and I feel even better now.
Fantastic. I suppose, like, what in terms of the agonist, it seems to be the biggest concern. Is there an alternative that can be used instead of an agonist during pregnancy, for example? It just seems, seems wrong, really, that a woman can, be brought along and then told, okay, well, the choice is you don't get pregnant because of this one drug. So I'm just throwing that out to anyone on the panel in terms of, should we be looking for another solution to help women with, what is it that the agonist gives that, does anyone have a view on that? I know I'm throwing a bit of a...
There is not really evidence that it's unsafe, but it's also not enough evidence that it's safe. So I think with my idea of the Parkinson's and Pregnancy Registry, we just could be able to collect more data also on women using an agonist in pregnancy, because I know there are women that have been using agonists in pregnancy, and I think it's safe. But then we can prove it's safe, and women can just continue the medication.
Well, that's
the one that I do know that is unsafe is amantadine, though. That's been shown teratogenic to the embryo.
So that's really important. Obviously, then we know that with amantadine, but agonists, which are quite commonly used, often in young onset, people, and there are many women I know who've had one child and then they haven't been able to have any others because of not being able to come off the agonist, and so it seems that maybe that's definitely something that we really should push to get more research on, because it's a huge thing for women, to want to have kids. For some anyway.
If I can briefly add, we have also the possibility, if the disease is advanced, to have the brain stimulation, and there are some publications we publish as well about the possibility, that the brain stimulation gives to have a safe pregnancy without a lot of problems.
Thank you, Elena. So just in terms of moving on to some of the sort of social questions people ask, Sonia, how do we make people to understand that females going through Parkinson's is even more challenging than males do? As in society, women are also usually viewed as the main caregiver. And I know there's a big area that you sort of researched for our paper in terms of that whole caregiving role and the burden on women.
Right. I mean, I think we're challenged in different ways than our male counterparts in our community. Like it or not, we are taking on a larger proportion of the caregiving responsibilities, or that feeling that we need to combine that with occupational demands and then trying to deal with your disease itself. It really can affect women in terms of their health, overall health. There's increased rate of depression in female caregivers. And female caregivers have less access to healthcare as well, or for themselves. And this is, I mean, I think we see it in our own lives as women with Parkinson's disease, that we do have that sense of sort of responsibility that perhaps our male counterparts don't have as strongly when it comes to house and home and family. I think it's important for us to not only recognize that as an issue, but also know what to do about it. So sharing stories with other women, receiving support from other women who are going through the same life experience. I mean, probably the best things I've learned from a practical standpoint have been from my girlfriends with Parkinson's disease who have gone through the same life experiences that I have. And then also educating and arming the multidisciplinary team that hopefully will be looking after women to identify those issues and give support, whether it be through counseling or through, social work or whatever a woman needs to optimize her quality of life.
Yeah, I mean, it's certainly, I think as a woman, I think we sort of take Parkinson's on almost like another to-do, where, and I don't mean to be biased here, but in terms of perhaps when the man has the Parkinson's, the woman takes on the caregiver for the man, but it doesn't quite always happen. And there's many men who are very supportive, but also I think it's probably women take it on as well. They don't give away the role,
when it comes to relationships, I mean, women are more likely to have a paid Parkinson's caregiver needing paid services, and they're more likely to end up in nursing homes. Now, this may be due to the longevity issue, but it can also be due to, the difference in terms of care. Yeah.
And obviously there's a concern, maybe, I know from the book Ending PD by Michael Oken and Bas Bloemen, the neurologist gone out of my head, but in terms of that book, was sort of saying, obviously, when you in a nursing home, often you don't get as much care for your condition for Parkinson's, so that's a concern, obviously, if women are ending up in nursing homes sooner. So in terms of, and then sort of following on from that, in terms of being the caregiver and taking on, this is another to do. One of the questions was, how can I better balance my time? Sorry, that's my timer there. So just to say, we started a bit late, so we're going to go 5 minutes over. So just in terms of how can you better balance your time to make you the priority, what would you say to women out there to be able to manage their Parkinson's on top of everything else?
Yeah, that's a difficult question, but I think you just should make yourself the priority often enough to be able to take good care of yourself. So ask the people around you for help, so you can be able to exercise, reduce stress, sleep well, and eat a healthy diet, since this helps slow off the disease progression. And eventually everyone around you will benefit from you feeling better. So you just every once in a while should put yourself first. Any other way.
Yeah. And I think one of the things we sort of said in the paper was, for women, it was quite hard to give up that role as being the kind of the main caretaker, and that's, the role in the family. And Sonia, I don't know, have you a sort of feeling in that, in terms of, having, I suppose, a loss of control of saying, okay, I need to give up I need to share out the responsibilities, I need to get support, I need to say no more.
Yes, I mean, I think it takes a lot of introspection, but you have to kind of redefine your role in some ways. I mean, what is a super mom? Is a super mom someone that's going nonstop, busing kids from one activity to the other, running around the yard? Or is the goal of you as a mother, a super mother, or super parent, to raise independent, empathetic, compassionate, productive members of society? And that's sort of the switch I had to make personally on my own when I was thinking about everything that I couldn't do because of my disease. And it really, for our family, turned out quite well. I think for my children, who are now 23, 21, and 17, they learned a lot about empathy, and they learned a lot about compassion. And the most important thing that they learned was that life isn't perfect. Things are going to happen in life. And it's how they face those challenges that really will define them as human beings. And so it takes a bit of a mind shift, because the standard sort of definition of what we think about when we say super mom is, really quite different than what it actually is.
Yeah, thanks a million, guys. And I'm just conscious now that we're kind of coming up for the last few minutes. And I know this is a bit of a curveball question at the end, but I noticed one question I checked the registrants was around DBS, deep brain stimulation for women. So just going a little bit back to the clinical side, there seems to be, delayed access to DBS surgery for women, but also in terms of, it seemed to be quite a few women commented that their DBS didn't work out so well, that their symptoms weren't as well controlled. And I'm just wondering, perhaps if I put this to Elena or Indu, is there much research in terms of looking at the difference of outcomes of DBS in men and women, and perhaps there are differences that came up quite a few times in the comments in the registrants tonight?
If I may, motor deep brain stimulation was started first to treat motor symptoms. And motor symptoms in women are a bit different because women have more dyskinesia compared to men. So which means that the parameter of stimulation, they have to be set up in different way compared to men. And we have to reduce the medication in a different way compared to men. And then we discovered that recently in the history of Parkinson's disease that sometimes non-motor symptoms can be much more disabling compared to motor symptoms. And women have different non-motor symptoms compared to men. So we know that anxiety, depression are much more evident in women compared to men. And most of the time, and I think that you know much better than me, when you are in the off states, yes, of course you are slowing down, but what you feel inside, this stress, this anxiety, and to be unwell, it can be much worse than to feel a bit, slow. And sometimes the brain stimulation does not work as good as the medication in these non-motor symptoms and we have reduced much more the medication to reduce the dyskinesia. So sometimes this perception that the brain stimulation is less effective may be also related to the non-motor symptom, which might not be so well controlled by the brain stimulation, which was first thought about the motor symptoms.
Thanks, Elena. And I think we need probably a webinar on it alone. And just to say that I know Kathy Monahan, who's a PD or WPC advocate. She had DBS and it was very successful. But I think we just need to maybe, another area for us to research for women with Parkinson's. So I just need to wrap up now before I get wrapped across the knuckles for running on too late. So I just want to thank our panelists tonight. It was a wide range of questions. And we, will try and also through the Women's Parkinson's Project through our email newsletter to answer in batches the other questions that people put in the application or the registration form. So just wanted to say thank you to everyone for turning up tonight. And I'm going to hand over to Eli to wrap it up and close it off. So thank you, everyone.
Thank you, Rochelle. Oh, they're getting rid of everyone on the screen. It's just me now. So first of all, thank you so much. I hope everyone enjoyed this conversation today. And I hope you're making plans to be with us next year in Barcelona for the 6th World Parkinson Congress, where this sort of conversation will continue in a variety of different formats. So I look forward to seeing some of you actually in person next year. So as a reminder, the recording of this talk, both in English and Spanish, and will be made available tomorrow or within the next day beyond after tomorrow. Please share them with your community. We hope this this talk will be viewed by many more than even the 670 some registrants. So I just want to say thank you to our interpreter team, Carlos and Elena. They were amazing. They did a phenomenal job. I switched into Spanish once or twice just to hear them. They were wonderful. And to Sabela for helping to coordinate the interpretation. I also want to thank our moderator, Rochelle, for her, first of all, approaching me to pitch this idea, and of course to all the panelists. And a huge, huge thank you to my colleague, Kathleen Jordan, who we would not be here with interpretation without Kathleen's hard work, and under pressure, she brought us all together. So thank you, Kathleen. And also last one, a thank you to Kyoa Kiran for again making this possible. So for those of you who stuck around to the very end, I'm about to announce a name of someone who won free registration to attend the Congress next year. That is a $700 value, so it's not a small prize, it's a pretty big prize. But Rochelle, I need your assistance in picking a letter.
Okay, M.
Okay, and then Indu, I need your assistance in picking a number between 1 and 10.
8.
Marion Fioretti. So Marion Fioretti, you just won a free registration to attend the Congress next year. Congratulations. We will follow up with you by email to confirm the process and get you your what you need to be able to register. So with that, I want to thank everyone. I know that there's a lot happening around the world right now. So on International Women's Day, I just hope that to all the women out there in the world, wherever you are, whatever your situation is, we hope that you're safe and that you're getting the things that you need to take care of yourself. Thank you, everyone. Have a wonderful afternoon and evening and morning, and hopefully we'll see you again soon.
Thanks, Eli.